So when treating a patient with COPD, one of the first things that you do is prevention. Smoking cessation is essential and is the key step in the treatment and is proven to reduce mortality. Usually, acute exacerbations of COPD are due to the bacterial or viral infections, and so patients need to get their seasonal flu shots and pneumococcal vaccines on time. The next is to give oxygen therapy. This oxygen therapy is quite an intense one, and not all patients require it. Some patients may require continual supply, but others only need it during sleep or during exertion. So there's a qualification criteria for patients who need oxygen therapy. They need to have either a partial pressure of oxygen of less than 55 or a oxygen saturation of less than 88%. You can also have a patient with a partial pressure between 55 to 59 along with polycythemia. Polycythemia occurs as a compensatory mechanism for hypoxia, or they could also have cor pulmonale. Patients with these systemic responses and an oxygen saturation of less than 90% also qualify for oxygen therapy. So to administer it, aim for an oxygen saturation of 88 to 92%. The aim is to raise the partial pressure of oxygen without worsening the acidosis. Administration can be done either through a venturi mask or a nasal cannula. A venturi mask goes at up to 4 liters per minute, and a nasal cannula should not go up to more than 2 liters per minute. This will last about 16 to 19 hours a day. The next best therapy is to give bronchodilators. Bronchodilators act on two receptors, the muscarinic receptors and the beta-2 receptors. Now, as a review, muscarinic receptors are part of the parasympathetic system. Acetylcholine binds to it, causing a calcium influx and resulting in bronchoconstriction. Beta-2 receptors are part of the sympathetic system. Norepi and epinephrine bind to it, causing an increase in cyclic AMP in smooth muscles, resulting in smooth muscle relaxation. Now, muscarinic receptors have short-acting muscarinic antagonists and long-acting muscarinic antagonists. Beta-2 have a short-acting agonist and a long-acting agonist. So example of a short-acting muscarinic antagonist would be ipratropium, a long-acting M3 antagonist would be tiotropium, a short-acting beta-2 agonist would be albuterol, and a long-acting beta-2 agonist would be salmeterol. So the next thing to look at is corticosteroids. They can be given inhaled, orally, or through IV. An easy way to remember this is that inhaled corticosteroids are for stable COPD, oral are for bad COPD, and IV is for very severe COPD. The oral drug used is prednisone, and the IV drug usually used is methylprednisone. The aim for COPD treatment is to improve the patient's quality status and preserve the lung function. A comprehensive disease management strategy is used to get maximal results with the patient's condition. So here I've listed out all the treatment mechanisms that we went through earlier in a ladder format to better understand how to prescribe. Smoking cessation is the single most effective intervention to reduce the risk of COPD. Once you get the patient tested against the GOLD criteria, you will have a better understanding of what combination of pharmacological therapy to provide. Then bronchodilators are introduced. These are the backbone for COPD. For mild to intermittent COPD, a combination of medications are used. An easier way to remember this is to provide short-acting drugs, short-acting muscarinic antagonist and a short-acting beta-2 agonist. You can use a nebulizer or metered inhaler to prescribe this. For moderate to severe cases, as in an FEV1 of less than 60%, long-acting drugs are given. A long-acting beta agonist along with a long-acting muscarinic antagonist. For very severe COPD, a triple inhaler therapy is given. This is essentially long-acting drugs along with inhaled glucocorticoids. An option for severe disease is to introduce a phosphodiesterase inhibitor. So phosphodiesterases break down the cyclic AMP. The inhibitor obviously causes the inhibition of the breakdown. So the increase in cyclic AMP eventually results in prolonged smooth muscle relaxation. The common drugs in this category would be theophylline and roflumilast. These are used modestly and only given to patients if they're not responding to standard treatment, as they cause intense side effects. If none of this works, then lung transplantation is indicated. So with acute exacerbation of COPD, it is defined as increased dyspnea and sputum production with or without cough. It can lead to acute respiratory failure and requires hospitalization and ventilation and could be possibly fatal. This is usually the result of a superimposed viral or bacterial infection in the respiratory tract. So as an initial management, the first thing you do is check for airway support with the mnemonic A, B, C, D. A is for airway support, B is to check for the breathing, what is their respiratory rate, if they have wheezing, if they have pneumothorax, and check for their O2 saturation. C is for their cardiovascular examination to rule out any differential diagnosis. D is to check for the consciousness level through GCS scale and to also check glucose levels. Now, once that's done, you give high flow oxygen. It's best delivered with a venturi mask as it allows controlled oxygen delivery regardless of the respiratory rate. Oxygen has to be used carefully in certain patients of COPD because some of them rely on a hypoxic drive for respiration. However, in an acute exacerbating setting, the patient will die faster from hypoxia than from hypercapnia. You can introduce the oxygen at lower doses and increase later if there's no hypoventilation and no acidosis. The next, bronchodilators and anticholinergics are given. Nebulized salbutamol of 5 mg and ipratropium 500 micrograms is given immediately and then 4 to 6 hours hourly. Nebulizers can be driven with oxygen or with air depending on the results of their ABGs. Corticosteroids are then given to patients that are hospitalized. Oral prednisone of 30 mg for 2 weeks is prescribed initially. Antibiotics are used in patients with a more purulent sputum or in evidence of pneumonia clinically or radiographically. You can give amoxicillin of 500 mg orally or clarithromycin of 200 to 500 mg. You should also give medication to prevent thromboembolism, so a low molecular weight heparin is introduced. And that's the end of COPD treatment. Thank you for watching.